And we're really happy Christa Cooper is joining us today. She's given us her time. Thank you. Christa Cooper is a physician assistant at Rush University Medical Center in Chicago. She's been practicing in the movement disorders clinic for over 6 years and has been a physician assistant for 11 years. She has clinical interests in deep brain stimulation and Huntington's disease. She's currently working on her PhD with a focus on research and education, and we're so glad she's joining us. Christa has also agreed to share her slides, so that will be available tomorrow along with this program. And hi, Toronto. Hi, New Jersey. And hi, Christa. Thanks for joining us.
Hi there. Nice to see everybody. I'm really excited to talk to you today about DBS. Thank you for that nice introduction. So let's get started. Let me share my PowerPoint here. Okay. Can everybody, can you see that?
You are good.
Okay, great. So I'm going to talk to you today about deep brain stimulation. What is it? How can it help Parkinson's disease? And I just want to kind of set a little disclaimer in the beginning that this is an overview of deep brain stimulation. So it's not, the following presentation isn't totally inclusive of all information regarding DBS. And I based my presentation mostly on the protocol we have here at Rush University Medical Center, but every center may be a little bit different. So don't be alarmed if some of the things maybe are not where you get your medical care, how the protocol is. And I encourage you, if you're interested in deep brain stimulation, to really speak to your individual medical provider if you have specific questions regarding your medical care. Okay, well, let's start really basic. So what is DBS? It stands for deep brain stimulation, and it involves the implantation of electrodes into the brain. Electrodes are just wires. So these electrodes produce electrical impulses that regulate the abnormal impulses in your brain that are causing Parkinson's symptoms. So you can see the picture on the right. Are two different types of wires that can be implanted into the brain. And you may be able to tell that there's 4 what we call contacts. There are these silver parts of the wire, and that's where we can provide stimulation. The wire is about the thickness of angel hair pasta, so that kind of gives you an idea of what we're working with. So deep brain stimulation is used in a variety of conditions, but in movement disorders, we primarily use it for Parkinson's disease, another condition called essential tremor, and for dystonia. Today, I'm obviously going to focus on Parkinson's disease because that's what we're interested in today. So DBS for Parkinson's disease, there are some symptoms of Parkinson's disease that respond really well to stimulation, and there are some that will not respond to the stimulation. So first, let's talk about what symptoms we think could improve with the DBS. So first is tremor. That's a really good indication for deep brain stimulation. If you have an uncontrolled tremor, a tremor that's not being controlled by medicines, it's interfering with your daily life, that may be a really good reason to seriously consider moving forward with DBS. Another thing DBS can help with is dyskinesia. That's the extra wiggling movement that can occur in Parkinson's disease. Sometimes it occurs at the peak dose of medication, and so DBS can really help reduce that. DBS can also help with muscle rigidity and spasms, and spasms including dystonia. So commonly, I'll hear the patients that I treat say that maybe first thing in the morning they have toe curling, or when their medicines are wearing off, they have muscle cramps and spasm, or a foot will turn in when they're walking. And those are different types of dystonia that can be really well treated with DBS. Another thing that it can help with is bradykinesia, which is a medical term for slow movement, and those motor fluctuations. So sometimes we refer to that as being on and off, but the fluctuations where you feel great when your medicine's working and then it wears off and you feel pretty terrible. since DBS is on 24 hours a day, it can help smooth that out. And then I mentioned there are some symptoms that we really wouldn't recommend getting DBS for because it just doesn't help. And those are things like cognition. DBS cannot help improve memory or improve focus or cognition. It really doesn't help with sleep or fatigue. The caveat, though, is if you're having a hard time sleeping because you can't get comfortable because you're so rigid or you're having dystonia, and then that improves with the DBS, then maybe your sleep would improve. But it really doesn't help with energy levels or fatigue during the day. We typically don't see any improvement in speech or swallowing, mood. So if you're dealing with symptoms of like apathy, depression, anxiety, that's not something that we would expect to improve with stimulation. And then balance and walking. So I put a little asterisk next to that because sometimes walking can improve if you have a lot of dyskinesia, a lot of that wiggling movement that's throwing you off balance while you're walking. Then the DBS kind of indirectly helps with the walking because it helps the dyskinesia. I also see some cases where people have freezing, where you're walking along and then your feet feel like they're stuck to the floor and you can't take another step. It's pretty common in doorways or in narrow hallways. If that responds really well when you take carbidopa-levodopa, then sometimes we see that it will respond to the stimulation. But I always counsel my patients that are moving forward with DBS that I cannot guarantee that. So sometimes that type of freezing will not respond to the stimulation. So it's kind of a maybe. And then any other non-motor symptoms. So I'm sure we all know some of the other common symptoms like constipation. That's not really something that DBS would help with, or drooling, any of the non-motor symptoms. So how do we decide who's a good candidate for DBS and who's not? This is just kind of an overview, but one of the criteria that we use is, do your symptoms respond to carbidopa-levodopa? So when you take your carbidopa-levodopa or a different Parkinson's medicine, are your symptoms a lot better, and then you kind of feel like they get worse when it wears off? There is an exception to this, though, which is tremor. So if your tremor doesn't respond to any of the Parkinson's medicines, we still find that it can respond very well to DBS stimulation. So that's kind of the exception to the rule. We also prefer to implant DBS in people that have either normal cognition or very little cognitive difficulties. The reason for that is, we're doing the surgery, we're really poking little holes in your brain with the wire, and so it's possible to have cognitive decline after the surgery. So we really want to make sure that your cognition is strong before we move forward with the surgery. And then age. This is very location dependent, so it depends on your individual medical center. I would say typically we try to implant people that are under the age of about 70 or 75, but certainly we have done DBS for people that are older than that, and it really just depends on the whole picture. So it's never just one thing that will include you as being a candidate or exclude you from being a candidate. We really look at the whole picture. Oh, but one more thing on age. I do encourage people that are interested in DBS and are maybe getting into their early 70s to start having serious conversations about it, because the workup before surgery takes a while. So it's not as easy as saying like, oh, I'm ready for DBS and I'm going to have it later this year. It can take a little while to get worked up. And then another part of the whole picture is any comorbid conditions. So that could be things like diabetes, high blood pressure, high cholesterol. So people that maybe have those things very well controlled or don't have those conditions are typically better candidates for DBS. And again, that doesn't totally exclude someone, but we take that into consideration when making a decision. And then stable mood. we really want to make sure that someone's not having something like suicidal thoughts or uncontrolled depression before undergoing a major surgery. And so that is something that we also evaluate before moving forward with the surgery. And a really good candidate for DBS is someone who's having quality of life issues because their symptoms of PD are moderate to severe. So if you have really mild symptoms and it's well controlled with medicines, maybe not the time to get DBS. So really we're focusing on quality of life and functioning. So again, I am basing the pre-DBS workup on what we do here at Rush. But one of the first things we do is something called an off-on evaluation. And that's where we have you come into the clinic. You don't take any of your Parkinson's medicines, including carbidopa, levodopa, for about 8 to 12 hours before the appointment. So when I do this for my patients, I usually try to schedule it first thing in the morning so they can take their nighttime medicines, and then they don't take any medicines before the appointment that morning. So it's just less uncomfortable for them. And so when they come in, they haven't taken any medications, we call that off, and we do a video exam. So I do the whole kind of typical Parkinson's evaluation with the finger taps and the hand movements and toe taps and all of that, and we video that exam. And then I have them take actually more than their normal dose of medication to get them to their best on possible and to bring out any dyskinesia. And then once the medicines are in their system and working, we do the same exam and video it again. So we can compare the off video and the on video. And I said to bring out the dyskinesia because we really want to see that on the video. And so that helps us kind of determine what the symptoms are, what is responsive to the medicine, and what's not. And it really helps me tell patients kind of what they can expect in terms of outcome. Another thing that we do as part of the workup is a neuropsychological test. So we're really lucky. We have 3 neuropsychologists here at Rush, and they do like thinking, memory, mood testing. It takes about an hour, hour and a half. They get really in depth, and they really can look at all aspects of cognition. And they can tell us if your cognition is normal, if there may be some impairments, but they're kind of mild, or if we think there's a dementia, Parkinson's disease dementia. Another thing that our neuropsychologists do that's very helpful is a mood assessment. So sometimes us PAs and the neurologists, we get so focused on the motor symptoms that we don't always delve into the mood symptoms. And so that's another important aspect. So occasionally, if it comes out that someone is having pretty severe depression, for example, then we will have them follow with, we also have a psychiatrist in our movement disorder clinic, and we'll have them see our psychiatrist and kind of get their depression under better control before we move on with the surgery. We also get an MRI of the brain. It's a really detailed MRI that looks at the areas of the brain where we might implant the stimulation, and it really helps our neurosurgeon kind of with his surgical planning, with how he's going to implant the wires. And we typically look at 2 areas of the brain, and we decide between those areas, and we look to see maybe which one looks a little healthier or larger, and that can help us decide on where in your brain we're going to do the stimulation. At Rush, the MRI is typically done with anesthesia because you have to be incredibly still in order to get the best picture of your brain. And so if you have dyskinesia or tremor or some kind of movement, you can't stay perfectly still during an MRI. So often we'll do it with some anesthesia. And then you also visit with a neurosurgeon, so just a regular appointment in the office to meet him, talk about surgical risk, talk about your individual risks, talk about the procedure, and then usually at that visit, they give you instructions for surgical clearance that can often be done with a primary care doctor. And so sometimes that might include blood work, it might include an EKG of your heart rhythm, it can vary. But that's the typical pre-workup. There may be some things that are tailored to a specific individual, but this is something that everyone at our program goes through. So let's say you've gotten through the pre-DBS workup, you've passed all those steps, you're cleared for surgery. So what happens during the surgical procedure? So once you're in the operating room, there's a small area of hair that's shaved and the scalp is washed. That's how we do it at our center. At some centers, they still shave the whole head. So that might be something that you'd have to ask your medical team about. And then where that area of the scalp has been shaved and washed, they inject a numbing agent into the scalp and then make a small incision. So they make the incision and they have to remove a piece of your skull in order to get to the brain to insert the wires. The size is about the size of a nickel, and usually it's done bilaterally, so one on each side. So once that piece of your skull is removed, a wire is implanted into the brain. And if you remember back to that first slide that I showed with the picture with the two wires, those are the wires that are implanted in the brain. And it's just the very tip of the wire that we're trying to get into the best location, because that's where we can provide stimulation. So it's important, we have a great neurosurgeon. It's important that you have a neurosurgeon that's very familiar with this process, because it can be difficult to get that very tip into a couple millimeter space. So they have to be pretty experienced with that surgery. And once we feel like it's in the best location, I had somebody ask me if the skull that was removed is put back. Well, it can't be put back because we need a space for the wire to come out of. So what we use instead is it's a medical grade plastic cap that kind of plugs the area of the skull that was removed, but it has a space for the wire to come out of, and then it's kind of clipped or held in place with that plastic cap. Then the wire is tunneled under the skin, and it's connected to an extension wire, usually somewhere behind your ear, but everything's under the skin. And that extension wire typically goes down, and a battery is most commonly placed in the chest. So like an inch or so or further underneath the collarbone in that area. And then I kind of mentioned the bilateral procedure. That's how we most commonly do it here. So if you are having both sides done, then this whole procedure would be done on both sides of the brain. Some centers do what we call staged procedures. So they'll do one side, and then they let you heal, and they program that, and then they'll do the other side at a later date. It just kind of depends on where you're getting medical care, what is typical there, and your individual case. And then those are just some examples of the battery that's put into your chest. I have a couple in my clinic, so when I do that off-on evaluation, I kind of bring out the battery. I just show people. I think it's kind of interesting to see what's going to be implanted into your body, right? So it's kind of nice to be able to hold it and see kind of how small it is and whatnot. So, like I mentioned, all of the wires are under the skin, so nothing is exposed. If you can see my pointer here, so in this picture, you can see this blue kind of halo around the very tip of the wire. So that's where the stimulation is being provided, and that's the most important part to get in the right location. So that is the stimulation, and the wire comes up through the brain, and you can see here is where the plastic cap is. And you can see the plastic cap, it doesn't fit exactly flush with the skull, so there can sometimes be a little bump on the top of the skull from that cap. And then the wire is underneath your skin, but over your skull. So it kind of looks like it traverses back through the brain on the back part here, but it doesn't. So once it comes up through that plastic cap, it's against your skull. It's not in the brain anymore. And then it is connected to an extension wire, typically somewhere kind of behind your ear. And that extension wire then is tunneled under your skin and connected to the battery that is in your, like underneath your collarbone, kind of in your chest. And so incisions are made on the top of the skull, behind the ear, and then on the chest. Like I said, you might have a little bump on the top of your head and also where the battery is in place. And sometimes people feel the wire on the side of their neck. Sometimes they feel like it's kind of pulling or can be a little uncomfortable, or sometimes they feel like the battery shifts a little bit. If that's really causing a lot of problems, the solution is to go back into surgery. So sometimes they just will reposition the battery or give a little bit more space for the wire so it doesn't feel like it's pulling. I wouldn't say that we do that commonly, but we have done it for a few of my personal patients, and they've just felt more comfortable after they kind of have it adjusted a little bit. So this gentleman had DBS, and I have a little arrow here, but if you can see, there's an incision on his skull, and then you can see a little bump. So obviously, if you have hair in that area, it wouldn't be very noticeable. But if you don't have hair in the area, you may kind of notice that bump there. And then this person had the battery implanted in their chest, and so you can see the scar there. I would think this is probably a kind of newer-ish scar. I have seen, when I kind of check scars over time, they tend to kind of heal pretty well from what I've seen with my patients. And then this gentleman, so you can see his battery in his chest. It's pretty prominent for him. Now, I wouldn't say that this happens to everybody, but for people that have less tissue, are petite or really thin, the battery may be a little bit more prominent in your chest. But it also can depend on where it's placed. But I just like people to know that could be the outcome. I had somebody tell me, I wish I would have just known that could have happened. I still would have done the surgery, but I just would have felt a little bit more prepared. And then that arrow is kind of pointing to the wire that's connecting to the battery. So I think to kind of the average individual, it would just look like maybe a tendon. But to the people in the know, we know that it's a DBS wire. So you've had the surgery. Now, what happens after the fact? So typically you stay about one night in the hospital, and that's to make sure that your pain's under control and that you just are recovering well. Sometimes people have symptoms that improve immediately after surgery, and that improvement can last for a couple weeks. And we call this a lesion effect. And it's just the simple act of just putting the wire into the location in your brain that's causing the symptoms kind of disrupts that area, and so your symptoms can get better, but it's temporary. So once your brain heals after surgery, that effect goes away. If your center is one that gives antibiotics, ours is, then you need to make sure to complete all of your antibiotics and follow all of the post-surgical instructions. So make sure you're following all the wound care instructions that the neurosurgery team gives you. You typically follow up with the neurosurgery team about 1 to 2 weeks after surgery, and often that's just for suture or staple removal, and then they do incision checks to make sure there's no signs of infection at all, because if there are signs, we really want to catch it early. And then you can return to normal activities about 4 weeks after surgery. So in the meantime, for those about 4 weeks, no driving, no bending over, no lifting over 8 pounds, or I've heard just no lifting something heavier than like a gallon of milk, which is probably lighter than that, and no flying. So you really just need to kind of, you can be up and walking around and doing things, just none of these activities. And then we recommend being cleared back to drive by your medical team after surgery. So all surgeries can potentially have complications, just like all medications can potentially have side effects. So we have to weigh our risks and our benefits, right? So in terms of brain surgeries, deep brain stimulation is a relatively low risk brain surgery. It is still brain surgery though. And completing all the pre-op evaluations really helps determine your individual risk. So some of the risks vary by center, but kind of just in general terms, there's about less than 3% chance of something called a hemorrhagic stroke. So that is when there's bleeding in the brain. So when we put the wire in, your brain starts to bleed. That's a type of a stroke. The more common type of stroke is when there's a blockage, like someone has high cholesterol, and there's a blockage in the blood vessel, and then that causes a stroke. That's the most common type. This type is a bleeding stroke. But it can cause the same symptoms though, like weakness or paralysis on one side. So that is something that we really look at when we get that very detailed brain MRI to see how healthy your brain looks. I mentioned the risk of infection. So you want to follow your post-surgical wound care instructions. If you're given antibiotics, you want to finish those. You also want to look for signs of infection. So if an infection occurs and it's not caught quick enough, sometimes we have to take all the hardware out because the infection can travel along the wire and get into your brain. That's very rare, and as long as you're watching out for signs of infection, your risk would be very low, but that is a potential possibility. Some people have walking and balance changes after surgery. It might be just kind of average surgical recovery, but every once in a while I have someone that says that they feel like their walking has just gotten worse after surgery than it was before surgery. Again, not common, but it is possible that that could happen. And then another kind of rare side effect is seizures from brain surgery. And then some side effects or complications that are more common and are just kind of associated with surgeries in general are pain, fatigue, and weakness. Now, those usually get better the further you get out from surgery. So about after a week or so, we would expect those symptoms to get better. And this really isn't a complete list of possible complications since I'm doing kind of an overview lecture here. So really, please talk to your neurosurgical team. And then, I mentioned the tip of the wire we're trying to get into an exact location. So that's another complication. That's the potential. If we don't get it into the best location, sometimes we will do what we call a revision surgery, where we'll take you back into the operating room and we will move the wire. So that is sometimes needed. So let's say you've had the surgery, recovered great, no problems. What happens then? Well, the system, we actually leave off for a whole month after surgery. So you've gone through this whole process, you had the surgery, and then you have to wait a whole nother month before we even turn the system on, which can be really frustrating. I hear you, but in order to do the best programming we can, we really need to let that lesion effect go away. So after you have the surgery, sometimes symptoms get better temporarily with that lesion effect, and we really need that to go away before we turn the system on. So that's why we make you wait usually about 4 weeks. So in that time, you still take your regular PD medications like you did before surgery. So once you get to that initial programming visit, which is about a month after surgery, for our center, we have you come to the appointment off medicines, which usually means no PD medicines for about 8 to 12 hours before the appointment. It's about a 2-hour appointment. Usually I take the whole 2 hours, especially if you've had the surgery on both sides of your brain, because I am trying to figure out with the tip of the wire where I have 4 locations I can stimulate. I'm trying to figure out which of those 4 locations is the best. And so I have to we repeatedly do exams and I adjust the stimulation to figure out which location is the best. And then the best analogy I have for programming is Unfortunately, it's not as easy as just turning it on or off. It's kind of like tuning a radio, but instead of just having one knob that tunes it, I have 3 knobs that tune it, and I have to get all 3 knobs into the best, all kind of working in concert with each other, and I have to have it in the best location of those 4 locations. So it can get kind of complicated, which is why that first appointment can be a little bit longer. I typically bring people back for the follow-up appointment in about 2 to 6 weeks. And those appointments are typically about an hour. So once we do that initial programming visit, the follow-up appointments are a little bit quicker. And finding the best setting can take time. So again, you know, you've waited a month to get the program turned on, but then we still have to wait to kind of try to find the best setting. So it takes at least a few visits. We usually don't find the exact optimal treatments on the first visit. And then rarely it can take 6 months or even longer to really find the perfect program. So that doesn't mean that you're not getting any benefit in that whole time. It just means we're really trying to find what's just right for you and fine tune it. And I really try to just get the best quality of life and the most functioning out of the system that we possibly can. And then once the system is programmed and you're doing well, unfortunately, Parkinson's still progresses. So over time, we have to adjust that program. So we found your best settings, and that might be good for a while, but then over time, we have to make adjustments. And that's typically about 3 to 4 times a year. We continue to see patients for follow-up. Now, I don't make adjustments every visit. Sometimes I'll go a whole year or longer and not really need to make any big adjustments. But that's kind of the typical follow-up for our clinic. There are 3 companies that have DBS hardware. They all have kind of their own special features, which I would encourage you to chat with your healthcare team about. I'm not going to really go into the specifics of the hardware, but the 3 companies are Medtronic, Abbott, and Boston Scientific. And each company gives you a remote, so you can adjust your own settings. And so that might be scary for some people. I have some people that say, oh, no, doc, you make the changes. I don't want to adjust it. But I feel like it's so empowering to have a remote, and you can kind of adjust your settings as you need to. Now, the caveat to that is we create parameters, so you can only go within the safety parameters that we set, which is just kind of a safety precaution there. And so the 3 remotes, on the left side, you can see the Medtronic is on the top left there. The Abbott remote is on the bottom left, and then the Boston remote is on the right. So those are just kind of what they look like. I think it's nice to just kind of see what you would be getting after surgery. And then while the DBS adjustments are made, we also adjust the medications. So sometimes that's why it takes a little bit of time to find the perfect settings for you, because I've got these 3 radio knobs, I've got these 4 locations, and I've got all your medicines I have to adjust. And trying to find the whole perfect settings for you can just take a little bit of time. So on average, medications are reduced by about 10 to 50%. Sometimes I get much more medication reduction than that, but it's really not my goal. My goal is not to stop all Parkinson's medicines. My goal is to give you the best quality of life and to use the DBS system to its fullest potential. I mean, you've had this system implanted in your brain. I want to use every possible benefit I can from it. And if that means we're able to get you off of your medicines or really reduce it, then that's great. But I never promise people that that will be the outcome. So we talked about surgical complications, but there can also be complications with the DBS system itself. Again, kind of rare, but these are some things that could happen. So one thing is skin erosion. So especially if you have thin or fragile skin, where that plastic cap is or where the battery is can just rub, and you can have some skin erosion in those areas. You can also have wound separation, which usually occurs right after surgery. It's not like a long-term complication. And that's just where those incisions that were made separate. And so that needs to be taken care of with the surgery team. And then the hardware itself sometimes has complications. So you can have what we call a lead fracture. So for instance, you have these wires that are going behind your ear and down into your chest. If you were to get into a car crash and have a whiplash injury with your neck, those wires are kind of fragile there. So that kind of really dramatic whiplash injury could break or fracture the wire. And then also very rarely we have something called lead migration, where the wire in your brain migrates a little bit. And so we were getting really good benefit, and then the lead migrated a little bit, and so it's not in the optimal location. But again, it's less than 1% of the time, so not very common. And then the stimulation itself can cause side effects. So this isn't a complete list, but some things that can happen are speech changes, muscle contractions, mood changes, dizziness, balance. The positive, though, for these side effects is if I just adjust your stimulation, they should resolve. So if we're just kind of stimulating an area of the brain that I don't want to be, maybe I'm causing speech changes, I can adjust the stimulation away from that area and hopefully resolve those speech changes. So outcomes and expectations. I just want to start by saying I wish we had a cure for Parkinson's disease. I'm really excited by all the research that's going on, but DBS is not that cure. So DBS is symptomatic treatment. Unfortunately, Parkinson's still progresses even though you have DBS. And over time, we have to make adjustments to the stimulation and medication. So even for my handful of patients that were able to stop medicines after surgery, they end up needing them again after their disease progresses. So new symptoms can also occur that really don't respond to the stimulation. So things like falls, that's not typically something that DBS can prevent from happening, and more cognitive decline. That's not something that DBS can treat or prevent from happening. And then at some point, even though you still get benefit from the DBS your whole life, at some point we might be limited due to side effects. So I may have tried every programming and adjustment I can possibly think of and do all sorts of complex, really cool programming adjustments. And we just get to a point where there's just not much more I can do where I'm not causing side effects. Now, that doesn't mean that the DBS isn't helping you and we just take it out. It means it's definitely helping you. We definitely want it to still be in your brain and working, but I can't really adjust it much more. And that's not something that happens quickly. That's over a long period of time. So like I said, it still provides benefit. We don't at some point say, oh, it's not helping, take it out. We don't do that. But people will develop more disability the longer they live with Parkinson's disease. And so just some facts to know. If you end up having deep brain stimulation implanted and then you need an MRI after the fact, even if it's a knee MRI or a hip or something totally unrelated to your brain, we either have to check your system prior to the MRI, or with one of those handy remotes that you get, you have to turn your system into something called MRI mode, and we would teach you how to do that. So if you end up having an MRI, you just need to notify your medical professional, and they can kind of walk you through that. Sometimes you also have to have an MRI at a specific center so that it's a specific MRI machine. If you were to have a surgical procedure, so let's say you need your knee replaced, you would turn the DBS off or put it into something called surgery mode during that procedure. And then other scans like CT scans, ultrasound, x-rays, those don't require any particular precautions with the DBS. You can leave it on during those procedures. And then I briefly mentioned EKGs before. So once you have DBS, if you need an EKG of your heart rhythm, you would need to turn your DBS off to make sure the EKG was accurate. Sometimes it picks up the electrical stimulation of the battery, and so the EKG like reading just looks funky and is not accurate. So in conclusion, DBS is a really great treatment for the motor symptoms in Parkinson's disease, particularly tremor, dyskinesia, slowness, rigidity, and the motor fluctuations, which is that off-on. It's not a cure, and Parkinson's will still progress, but it can continue to provide benefit for the rest of your life. Pre-op testing really helps determine if you're a good candidate for deep brain stimulation and your individual risk for the surgery itself. And then the programming of the stimulator takes time, and we have to make adjustments as Parkinson's disease progresses. And then I think that's all I have for you. So I am just going to stop sharing my screen so I can see everybody, because I've just been staring at my camera and I can't see anybody.
Thank you, Christa. This was so informative. I know I've learned a lot, and I really did appreciate the one slide about what it helps and what it doesn't help, because I feel like we get a lot of questions about that. So do you want to get started with some questions? My first is kind of, when people, and I know I'm going to keep this specific to you because, you know, obviously you can't speculate. When people with Parkinson's, they're meeting with you, is there almost like a window of time where you're like, it's relatively early, the meds are working, but on the other hand, you also know this is a progressive disease. Like, what are you looking for when, and do you usually bring up the conversation of DBS? Does it usually get brought up to you? What does this look like when it's kind of like, hey, we're going to maybe start going down this path? What does that really look like? And
yeah, so in my clinic, I usually bring up DBS because I program it. So I do all the off-on evaluations, I program the system, so I'm very familiar with it and very familiar with like what's a good time. But I find that for maybe some providers that aren't as familiar with it and don't use it on a daily basis, they may not bring it up. And so I would really encourage patients, if this is something you're thinking about, to bring it up. I wouldn't wait for your medical provider to mention it, because they might not, if it's not something that they do frequently. I sometimes see patients that are referred, and I feel like, oh, I wish they would have been referred like 5 years ago. I think their quality of life could have been a lot better had we done this earlier. But then I've also seen people that are referred way too early, like they just got diagnosed 6 months ago and now they're referred for DBS. So there's definitely kind of an in-between time. And usually how we decide is, how complicated is your medication regimen? Is that really impacting your quality of life? How well are your symptoms controlled? So are you on carbidopa-levodopa 4 times a day and you're doing great? We probably don't need to do brain surgery. If you're on carbidopa-levodopa, you're taking it 7 times a day, you're also on rasagiline or Nupro patch or Comtan and Tacopone, and it's really complicated, and you're having these off-ons, or you're having these peak dose dyskinesia, or maybe you're someone whose tremor has never improved with carbidopa-levodopa or any of the medicines, then we would definitely want to think about DBS and not let you live like that for years and years.
Of that window, we got a question, and I had to look it up because I wasn't, if a cure is found, like Ambroxol or Bunatinitab, how do you back off or out of the DBS stimulation as you get better? But I will point out that I did look it up, and I'm like, one of them, Ambroxol, I'm like, it's not even set to close the study until 2028. So I'm like, we obviously have a lot of time. And somebody also asked, like, can you ever turn this off?
Yeah, you can. Yeah, so you can turn the system off. You could take it out, I guess, if we needed to for some reason. But I wouldn't, although there's a lot of exciting research going on, I wouldn't have your quality of life now suffer because you're hoping for a cure later in the future. I can't particularly say, because I can't predict the future, but I can't say if you had DBS, you wouldn't be allowed to get a quote unquote cure. I would assume that would be some kind of medical intervention, and so you would still be able to get that. I will say though, sometimes this research that's going on, especially with like alpha-synuclein, the research is really recruiting people that often have not been on medicines yet. So they're within the first couple of years of diagnosis, they're not on medicines, and that includes not having got DBS. Now, we wouldn't usually do DBS in someone who's just 1 year out diagnosed and has never tried medicine anyways. But I just like people to know that sometimes having DBS will exclude you from some of these research trials.
There was kind of a follow-up question about it. Isn't it dangerous to turn it off for a long period of time? Because I guess there's a warning on the manufacturer's literature that if you've had DBS for over 5 years, you could experience life-threatening symptoms if something happens.
Yeah, absolutely. You don't want to just be turning it off for no reason. You turn it off, like for surgery, you turn it off, but it's right before surgery. And then you're under anesthesia and your airway is protected because you're under anesthesia. So they usually have you like intubated or they have airway protection for you. And then as soon as you're out of surgery, you turn it back on. We don't have people just turn it off willy-nilly for no reason. You don't just say, I don't want my DBS this weekend and I'm going to turn it off. Absolutely not. And if you've had it for years and for some reason it suddenly turns off, like you were in a car crash and that lead behind the wire behind your ear, like fractured and broke, then you would have a sudden loss of stimulation. Now that's very, very rare, but that can be life-threatening, and it may have you obviously in the ER, maybe ICU, because that sudden stopping of stimulation can be really dangerous.
This one you kind of answered, but I did just want to clarify because someone asked, if you have a thin neck, could you feel or see the wire that is tunneled under? And I feel like you kind of answered that when you showed the picture, but I did just want to verify, yes, that probably is that situation.
Yeah, you can. I mean, if you're kind of thin, you don't have a lot of tissue, adipose tissue, fat tissue kind of in this area, it may be more pronounced. I think to the average person, it probably just looks like, like a wire, or not a wire, like a tendon or something. I don't think most people would really notice it, but yeah, you may be able to see it if you have a thin neck. The battery itself, it's most commonly placed in the chest. I have a couple patients where it's actually in the abdomen. So the extension wire is much longer and it's down into their abdomen. That's not typically the first choice of where it's implanted, but it is an option.
Somebody actually asked if it's always placed on the right side, or is that just the picture showed that?
I've been pointing to my right side, but it's most commonly at our center placed on the left side. There is one company that, because of the software system and the stimulation, they recommend, I believe, it on the right side. But yeah.
Question, is this an awake surgery? Where are you able to verify placement with some test impulses in the operating room?
That's a great question. We at Rush are actually currently doing research on what we call awake versus asleep surgery. So historically, this procedure has been done awake. And so what that means is you're asleep for like the drilling part, but once the wire is placed, they actually wake you up and they turn the stimulation on in the operating room. And so like if you have tremor, they turn the stimulation on, they see your tremor is better, so maybe it's in a good location. Or maybe you start to have a side effect, and so they think maybe it's in a not great location. They also can use recordings. There's different sounds that the different areas of your brain and neurons can make. And so they can use that recording as well to help with the location. So that's what we would call an awake surgery, and that's kind of the traditional way. Now, more recently, they're doing something called a sleep surgery, and not all centers offer this, so you'd have to kind of talk to your specific neurosurgeon. But that's where you're under anesthesia the whole time, and when you're in the operating room, they do either an MRI or a CT scan, and once the wires are placed, and they compare that with the MRI you had before surgery, and then they can try to see if the wires are in the correct location, just using imaging. So it's both is the answer. It could be either one, depending on your center. We do it both ways.
Someone asked, have you ever had any situations where the DBS has affected the effectiveness of other neuromeds?
Affected the effectiveness, like it has made the medications work better or less? No, I haven't seen that before. It usually, sometimes it can, with the stimulation on and your Parkinson's disease medicines, sometimes like your dyskinesias get really worse, but that's not because the stimulation made the medicines work better or worse. It's just the combination of the two together caused worse dyskinesia. So we have to bring down the medicines.
There was a question about having PSP or like a Parkinsonism. Does that exclude people from DBS?
Yeah, it typically does. Yeah, we really haven't seen that DBS is helpful in the atypical Parkinsonisms. Extremely rarely. So, like for example, I'm also in the Huntington's disease clinic, and so they can get something called dystonia, which is an indication for DBS. So we don't implant DBS for Huntington's disease, but for this particular patient, their dystonia was so impacting their quality of life, we ended up doing it basically as like compassionate care. So we weren't necessarily sure that it would help, but it was our only option. And we don't really see that it helps in the atypical Parkinsonisms, yeah. And especially like for things like Lewy body dementia, because there's the cognitive aspect, it could actually worsen it. And so we definitely don't want to do it in an atypical Parkinson's and then have you be worse after. That would be terrible.
There was a question about, are you familiar with the state-of-the-art adaptive DBS that's also called self-adjusting? Could you talk a little bit about that?
That's not currently like FDA approved, but it is in the works. And so that would be where the wire, the tip of the wire that is providing stimulation also kind of reads your brain waves and adapts. So there's certain waves that are associated with tremor, certain waves that are associated with dyskinesia. And so our goal is to have a stimulator that adapts and changes itself in response to your brain waves. So we're not there yet. It's not something that I have available in clinic, but it is being researched.
There's a question about the battery. Is there an advantage to a rechargeable or replaceable battery?
Yeah, great question. Wow, we have some really informed people. I love to hear that. So the batteries, there are rechargeable and non-rechargeable batteries. So non-rechargeable batteries, this is a ballpark, but they typically last 3 to 5 years. And it can depend on your stimulation settings, how high they are, how much battery drainage we're using, and the company. So that means every 3 to 5 years, you have to go back into the operating room. Just the area in your chest gets cut open. The old battery gets taken out. The new battery gets put in and connected. So every time you do that, there's a risk of an infection, right? Anytime we cut into your body, there's a risk of an infection. So the advantage to that is you don't have to think about your battery for 3 to 5 years. So you don't have to think about charging it weekly or whatnot. The disadvantage is there's more surgeries. Now, the rechargeable batteries are said to last about 15 years, so much longer, but you usually have to remember to charge it weekly. And it is kind of like a wireless cell phone charger, you know, those little like circle like pads that you put your cell phone on. It kind of looks like that, and it just charges right through your skin. You just put it over your skin and it connects to the battery and charges it. And I have some people that I see that have the rechargeable and they just love it. It's because they don't have to worry about the battery dying. Now, I had somebody that forgot to charge it. So it died, so we had to charge it very quickly. So that's a risk. But in the non-rechargeable battery, especially during the pandemic, when people weren't coming and following up, I also had people where their battery died because they weren't following up, because I checked the battery level at every appointment. And so unfortunately in the pandemic, if someone, you know, we canceled the appointment at the beginning of the pandemic and then they never called and rescheduled, or they didn't show up for another one, maybe they had COVID, that could be a problem. But I would say for the average person, it's not a problem. If you're responsible, you follow up, you recharge your battery. It just kind of depends on patient preference. I don't usually push one way or the other.
I know you need to go soon. One more question. Is there a lifetime for, I'm going to assume the equipment, the DBS equipment itself, not the battery, but just, is there a lifetime for this?
Oh, like a lifetime warranty or what? Or
I guess that like, would it ever need to be replaced? Like the battery can go, I need a new charge. Like after, say you get it relatively and you got 20 years with it, is it still going to be okay? Or is it like, yeah, maybe after 15, you need a new one?
No, it should be okay, but it is a potential that there's some erosion. And I think that is in the older versions, because DBS has been around a long time and the technology has really advanced. So I think in some of the older implanted wires, there was some erosion now after like 15 plus years. But it's not something that I've seen commonly in a lot of the newer patients. I mean, I've been only doing this 6 years, so I've certainly inherited patients that have had it for 15 or so years. But I wouldn't say it's a common issue.
This was incredible. You gave such wonderful information. We're so grateful. As usual, and PMD, we have a tradition, our wave of gratitude. Thank you so much for giving us your time today. We really appreciate it.
Thank you. It was great to chat with everybody, and I hope everybody has a good day.